moving on to the next part of our session, which we will look at managing HCC, surveillance to newer treatment paradigms, and it's an interdisciplinary discussion. For this, I would like to invite Dr. Chandrakanth, medical oncologist from NH Howrah, Kolkata, to moderate the session. In the same panel, we have Dr. Shyam Bisht, who is the radiation oncologist from Medanta, Gurgaon, Dr. Viraj, medical oncologist from Shelby Hospital, Ahmedabad, Dr. Sujay Srinivas, medical oncologist from Bharat Hospital, Kottayam, and Dr. Amit Rastogi, who is our liver transplant surgeon from PSRI in Delhi, and Dr. Venkata Pradeep, a medical oncologist at Shankara Cancer and Research Institute at Tejpur. Over to you, Dr. Chandrakanth. Sir?
Right, I'm just joining.
Okay, sir. So while Sir joins and shares his screen, can I just get a confirmation that I can see Dr. Sujay, Dr. Amit Rastogi, and Dr. Venkata Pradeep? Is Dr. Viraj, Dr. Shambhisht, and is Dr. Viraj and Dr. Shambhisht have joined? Okay, sure. Thank you, sir.
Right. So, well, good evening, all of you. So I was supposed to moderate in the nth moment. Dr. Anand had to moderate. So I'm there accidentally here. So with my limited knowledge, let me just take you through the panel. I think my slides are visible and I'm audible also.
Yes,
right.
Sir.
Right. So I just prepared some slides along with the Astra slides that was given. So this is the question about biopsy. Okay. So the question is, under what circumstances do you want to do a biopsy? Lirats is specifically designed for at-risk patients. At-risk are the ones who have cirrhosis, or they are the patients who have chronic hepatitis B. So in which patients would you do a biopsy? So I can request one of them in the panel. Do we have Dr. Shyam Bisht?
Yeah, hi.
Yes,
so for the biopsy, in case of if it is a clear-cut Lirats 4 and 5, we know the radiological finding, the arterial phase hyperenhancement, and central washout, non-ring washout, and some other features. So Lirats is very well standardized in patients who are at risk, mainly the cirrhotic patients, patient of HBB. So in those, if there is Lirat 4, 5, you don't want to do biopsy. Where do you want to do biopsy? In case if there is a Lirat M, which is malignancy, but not definitely HCC in those cases, where we don't see a good elevation of the AFP or PIVCA. In cases where there is, for example, a disproportionately larger lymph node, small primary, which may be a mixed cholangio HCC or a cholangio in those cases, but not classically. We don't, if imaging is enough, in cases where there is a Lirat 4 and 5, so we don't do a biopsy in those cases.
Right, sir. Dr. Viraj, any thoughts? Do you do biopsy in your patients? What percentage do you do biopsy?
Yeah, so good question. I biopsy almost all liver masses unless a surgeon is going to go in and operate it. Because even though we have Lirats 5, we have two data sets, one from the UK registry and one from the French group, saying that even if you are Lirats 5 in the background of cirrhosis and classic HCC lookout, you would still be wrong in 10% of cases. And that's point number one. And point number two, now we are in the era where we are trying to fish out any molecular profiling. So tissue always helps. And because we also do trials at our center, so all trials with regards to HCC mandate a biopsy.
Are there any experiences of a driver mutation HCC?
I recently got a FGFR mutation, not a fusion. So of course the question comes that are we missing out a mixed histology there? So we don't know that. but we're still doing out, right?
Can I come
Right.
in
So I
and
think
say
that was
Can
new
I
for
come in?
us.
Yeah.
Sure, sir. Sure.
My views are completely opposite of what Dr. Viraj said. We as a surgeons would not do a biopsy of liver tumor, especially in a situation where there is cirrhosis and you feel that this is HCC. Right, 4 and 5 are obviously very, very specific. Yeah, I would agree with the point that if you are not planning any surgery, you're not planning resection, obviously cirrhotic resections are limited, and definitely you're not planning transplant, then you can do biopsy with the intent of doing these newer markers and these things. But otherwise, all patients with lesions in liver, if they are cirrhotic, they fall within the criteria, they should be offered transplant. And biopsy in fact becomes harmful because technically, apart from the complications of biopsy, you can cause seedlings. So in situations where you are planning that the patient does not want to undergo transplant, or resection is not possible or not feasible, and definitely medical treatment, then maybe biopsy can be done. There is a group in Toronto which does biopsy for tumors before transplant, saying that if it is high risk and then recurrence and all those things, but all those things are little, that's the only center in the world that does biopsy for the prognostic markers and other things before transplant. But yeah, so if there is surgery, you give them the option. If there is no surgery, then probably biopsy and whatever discussion can be.
Right, sir. Right.
No, I think so. That's what I said, doctor. That if my
That's what he
surgeon is
said.
going to go in,
That's what
that's the only time I don't do biopsy.
Yeah.
Right.
Hi.
Right, Dr. Amit, the question on the screen is for you. Who are the ideal candidates? Who are the expanded candidates? And who are the candidates in the era of systemic therapy you would consider for transplant?
So as you mentioned, the above 3 are almost the classic indications for transplant. Patient within Milan's or within UCSF or up to 7, all these criteria, they are fairly standardized, and we have long-term results both from DDLT as well as from LDLT that patients falling in these criteria, transplant becomes the best option because of cirrhosis and this. Patients beyond this criteria, there is a debate. Some of the debate is a little bit settled. Some of the debate still remains, and the protocols remains institutionalized. So in the criteria that you've mentioned, I don't think there is much argument the patient should undergo liver transplant. Beyond these criteria, the criteria have extended. See, you've heard, once you read all these things, there is something which is known as metro ticket concept. The concept is the farther you go, the higher the price you have to pay. It's like a metro train thing. So people have done up to 10 centimeter total tumor volume. Ultimately, many centers, especially in LDLT, I'm not talking about DDLT.